right, let's begin. I hope everybody is ready. Ready, yeah? Okay. Again, good evening, everybody. So today we're going to wrap up everything that we've been covering from the beginning of GIT. We've been covering the symptoms in GIT, right? And I've decided to just wrap everything up today because I just feel like it's just getting a little bit draggy, and we should start talking about diseases as soon as possible. And that's not like the main reason, but well, it feels to me it's getting a bit draggy. Also, then the second reason is that I feel that the important problems that we need to talk about before talking about diseases have already been covered, and they've been covered quite extensively, and I think they are I think the base and the foundation that we've created um, so far for the first few weeks of GIT is good enough for us to begin talking about diseases in GIT. So that's why I thought let's just wrap everything up today. And because what I plan to talk about today, what I plan to cover today, they are mostly not, I wouldn't say they are not important, but the explanations that if we were to go into great depth into these things that we are going to talk about today, I don't think that they are very clinically significant unless we wanna unless it's for a specialty program or um, if even if it's not a specialty program, probably it would be for in preparation for any board exams, for example, USMLE, that is mostly step one, and that is mostly on physiology and biochemistry, and that is not entirely clinically significant in a hospital setting. Of course, they are important as well, talking about physiology, talking about well, different things that in in the molecular level as well, in the genetics level as well. Of course, they're important. They are, of course, important. But again, like what we've talked about earlier on, some symptoms that we've covered, um, they are quite overly romanticized. And I think that if we go in depth with all this, the things that I want to cover today, I think I would be doing it I don't think it will be just to talk about them, and I think I'll be over romanticizing on these symptoms that we're going to talk about today. So therefore, what we're going to cover today, I'm going to try my best to be as holistic as possible, and I'll point out some points that that I will let you know that these points are worth reading up on. I may not cover them, but I'll just say it out loud. Just point it out to everybody so that if you would like to read up on them, which I highly encourage everybody to read up on, you can. Okay. Of course, maybe to in the foreseen future, we probably are going to cover them at least. But for today's class, I've decided not to go very much in depth, and I'll just try my although to a certain degree, I'll try my best to still um, make it relevant and make it something that we need to know. Okay. So all right. So let's begin. Um, or in other words, let's wrap up. Okay. So to begin our final wrap on the major problems in GIT, we'll start with dyspepsia. Okay. Also, during my preparation for today's class, I just feel that some of these symptoms um, they are quite there are disparities again, like what I've pointed out earlier on for different diseases and different symptoms. There are disparities in between different resources and all that. And sometimes we in school as well, we sometimes get confused as well, because some teachers would say this, some teachers would say this, and some professors would say this, and someone would also say this and all that, and we end up being confused. Throughout my preparation for today's class, I've been reading up on different textbooks and different resources, and I find disparities in them too. So in other words, what I can conclude is that our teachers are also confused just as well as we are. So to say that what they're teaching us is completely wrong, it's not fair as well. But this disparity that these teachers, our teachers, might have is the same way that we is a result of what we study as well. So I'll try to point out which resources are saying what, and what who is saying what, and I'll just let you decide on what to consume. And sometimes you don't need to consume them. Sometimes you just need to know that this one says this one says this, and whether it will be important in a clinical setting, it will still be up to you to decide on that. Okay, so all right, let's first start with dyspepsia. Dyspepsia, right? Uh, Generally speaking, a very layman definition of dyspepsia is just indigestion. If you really want to go into medical definition of dyspepsia, although the term dyspepsia itself is quite ambiguous. A lot of gastroenterologists and the specialists and professionals of when it comes to the study of the GI tract, they don't really have a conclusive definition of what dyspepsia is. Some of them are saying that it's just plain indigestion. Some of them are saying that it is painful indigestion. Some of them are just saying it's just problems with the GIT, and that is very, very, very generic, right? So in conclusion, from all this different inconclusive views of different people and different professionals, basically dyspepsia is painful, difficult digestion. Simply put, painful. If you really want to just wrap everything up, it is painful. Painful and difficult digestion, or painful indigestion, simply mean painful indigestion. Um, a lot of times, the term dyspepsia itself refers to mostly problems in the upper GI tract rather than lower GI tract, and simply because the symptoms are mostly um, they are manifested in a pattern that reflects more of upper GI than lower GI. So that is why some resources um, might just cover, when they talk about dyspepsia, they might just only cover upper GI problems and not GI. And that means, we all understand what upper GI means, right? From the mouth to what is proximal to the ligament of triads, anatomically speaking, right? So again, but then again, some resources are saying that dyspepsia is also reflective of lower GI, and it is reflective of the entire GI tract and not merely the upper GI problems. And some problems that patients have are sometimes reflective of what a typical dyspepsia is, but when we really investigate the problem, we don't really see any structural problems in the in that patient itself. And what I mean by investigating and investigating structural problems, of course, is to do a visual examination of the tract itself. And what I mean is endoscopy, right? And also, well, biopsy, of course, if you want to rule out any oncological problem or any malignancies and stuff like that. So there's that. But that is why they've kind of divided dyspepsia into two different forms. One is the organic part of dyspepsia, and the other one is the functional part of dyspepsia. Functional part. So organic part of dyspepsia is mostly reflective of the an ulcerative nature. The problem is mostly reflective of an ulcerative nature, whereas um, functional dyspepsia is reflective of non-ulcerative problem. Non-ulcerative problem. So that means um, the problem may, oh sorry, everybody's looking at my tea. Uh, that means that the ulcerative dyspepsia, so as to speak, so in code, is more of an inflammation part of the problem is more of an inflammation. It's inflammative in nature. Inflammative, is that even an English word? Let's just say it's an English word. Inflammative in nature, whereas the functional dyspepsia is mostly non-inflammative in nature, right? And you might also you have probably understood or was taught that dyspepsia is divided into gastric dyspepsia and intestinal dyspepsia, right? So that is the some resources are saying that as well. But there are some resources that don't really agree that that dyspepsia is divided into gastric and intestinal, mainly because there are people who believe that dyspepsia is mainly upper GI problem and not any lower GI problem, which is reflective of the so-called intestinal dyspepsia. But I'm just gonna just point it out there that okay, there's organic and functional. I got this from the resources in the UK and also in USMLE as well, and they called it non-ulcerative dyspepsia. So it means there's non-ulcerative dyspepsia or functional dyspepsia, and there's the normal dyspepsia. Okay, there's that. Um, Also, they've kind of the signs and symptoms of this dyspepsia. If we don't really divide it into gastric dyspepsia and intestinal dyspepsia, by the way, the division of the signs and symptoms of dyspepsia into gastric and intestinal is mostly in Russia. I did not come across such division of signs and symptoms of dyspepsia in non-Russian literature. So there's that as well. So let's just let's just talk about non-Russian literature just yet. They have kind of they've kind of summarized the problem of dyspepsia into this acronym called alarm symptoms. ALARM, alarm, symptoms. S in the symptoms is also one of the the acronym. So A stands for anemia. A stands for anemia, and that's mostly iron deficiency anemia. Iron deficiency anemia. Mainly because why is it iron deficiency? Because sometimes bleeding can happen and all that, and well, that's iron over there. And sometimes there's malabsorption of iron, and there are probably problems in the protein, the transferrin protein, and also well, basically just anemia. So A is anemia. L, loss of weight, stands for loss of weight loss, but well, loss of weight because alarm, right? L has to start with an L. Then A is anorexia, anorexia. It means severe wasting of the body. And not merely the psychiatric problem, because that's anorexia nervosa and bulimia nervosa and stuff like that. Okay. R. R stands for recent onset of progressive symptoms. Recent onset of progressive symptoms. M. Melena. I forgot what M stood for. M stands for melena. Melena or hematemesis. Hematemesis. Meaning that there's bleeding somewhere, upper or lower GI. Hematemesis, we all understood it, right? We all learned it before, the upper GI and lower GI bleed. Hematemesis means well, vomiting with blood. Melena means dark, tarry stool, right? S. S stands for what does S stand for? How can I forget what S stands for? 1 second. Yeah. How can I forget what S stands for? Okay, yeah. I had another word, the medical word for it. Swallowing difficulty, S. Swallowing difficulty or dysphagia. I had dysphagia in my head, but I did not. I couldn't find any. I couldn't find a D in alarm, so I was like, oh, what was that? Okay, so S in swallowing difficulty, dysphagia. So ALARMS, right? So these signs and symptoms are not really used. You can see that they are not really divided in, so as to speak, the into gastric dyspepsia and intestinal dyspepsia. Okay, so let's go into the Russian part, Russian division of dyspepsia, and that is into gastric and intestinal dyspepsia. Like we all understood, probably you've already learned them in third, fourth year, definitely. Propaedetics and also in therapy as well. Definitely I've covered this somewhere. So in gastric dyspepsia covers your pain in the epigastric region. It covers your weird taste in the mouth, ranging from heartburn, irritation, nausea, and vomiting. Whereas your intestinal dyspepsia refers mostly to lower abdominal pain, constipation, diarrhea. That's dyspepsia. Okay. Why is it important? Why do the Russians think that it's important to divide it into upper and lower GI? Simply because they believe that the problem in digestion is not merely to generalize the problem in digestion into mainly in the upper GI, and that is from the mouth. You know, we start our carbohydrate digestion in the mouth to the very end of duodenum, of course, these are the main part where digestion happens, right? And absorption as well, and not really that much when it comes to the large colon. But they believe that the dyspeptic problem is not merely just the digestion or breakdown of food and nutrients and the absorption of the absorption of them in this area. The absorption of water and the formation of stool is also reflective of what constitutes as digestion, right? So that is why they don't they are not fans of the overgeneralization of dyspepsia into just problems in the upper GI. Ergo the diarrhea and constipation and all that in the signs and symptoms as they um, included as well. So that's that. So let's now talk about non-ulcerative or non-ulcer dyspepsia, and that is your functional dyspepsia. The Truthfully speaking, both all of the resources talk about this. Not just most, all of them talks about this. So it means that it's a legit thing. It's not just a discrepancy between different regions of the world and stuff like that. So most of them, all of them, talked about non-ulcerative dyspepsia or functional dyspepsia. If you really would like to go into functional dyspepsia, it's a very big topic to talk about. But I'm not going to go in depth with it. So, but basically, the problem with functional dyspepsia is actually a very big problem. Simply because they don't know what's wrong. The cause is unknown. They've ruled out everything there is because most problems are reflective of the normal dyspepsia that we've talked about earlier on, and most problems are solved um, under that. Well, yeah, or some of them not actually. Um, but if we really want to be objective and to have like a concrete reason, of course, it's the usual ulcerative, the usual dyspepsia that we talked about. But functional dyspepsia, it's a problem because people don't know about it, and it takes a while for us to land to that pad, and to only then understand that it's a functional dyspepsia. And the thing about dyspepsia, this non-organic dyspepsia, in opposed to what we've talked about earlier on, the organic dyspepsia, um, is that the problem lies in the GI, in the peristalsis, mostly the peristaltic part of the GI tract. Some sometimes it's the motility of the GI tract. Sometimes it's just nerve problems and things like that. These are non-organic causes, and that's, I mean, of course now I'm pointing it out here, but I just also said earlier on that the cause is unknown. But it seemed that the signs and symptoms are reflective of problems uh, the movement of the food. So, the signs and symptoms of functional dyspepsia include postprandial fullness. What does that mean? Postprandial. I hope maybe all of us know what that means. It means that after eating, postprandial. After eating, fullness, feeling of postprandial fullness. Early satiety, it means that the person feels full very early, eating a little bit and feels full already. I know some of us um, might have that problem maybe. And some people say, "Oh, I just have small stomach." Really? Never know. Um, and alongside these signs and symptoms, there is no evidence of and of structural damage. It means that you've already done your biopsy, you've already done your endoscopy and all that. Nothing significant is found. So, with this conclusion, functional dyspepsia. Okay. If you would like to read up on this, there is a set of criteria that you can tick, or not really tick, but that can help you to really diagnose functional dyspepsia. It's called Rome 3. I don't know if they've updated it. I've not checked. But just like constipation, remember when you covered constipation, there's also a Rome criteria for it. But for functional dyspepsia, there's also a Rome criteria for it. Just like constipation, it's nothing that deep. Why is it called Rome? Because they just simply like the name. So yeah, that's that. So how do we treat this problem? How do we solve this problem with when a patient comes to you with dyspeptic problem? Of course, from the beginning of our GI class, I keep repeating myself that what we're covering is mostly symptoms and important signs and symptoms, or syndromes, as the Russians would put it. Some of them are syndromes. By the way, some of them are syndromes. Diarrhea and constipation, to them, it's not a syndrome. But anyway, uh, as I mentioned earlier on, all these things are just problems in GIT that we are covering. It means that there is an underlying problem. So to even if we don't know the underlying problem, the very least, at least we can treat these symptoms that we've been studying so far. Okay, so how do we handle patients that come to you with dyspepsia? Of course, you need to find out what the underlying problem is. If it's gastritis, if it's problem in the stomach, in the duodenum, where it is, what it is, and all that. So first, of course, you need to do your concrete gold standard of test, and that is your endoscopy, of course. That's a given. You of course have to do it. Your fibrogastroduodenoscopy, FGDS, and also um, not just from the upper tract, and also the from per rectum as well. And your endoscopy is also necessary to confirm that. So our after doing that, of course, you need to prescribe some things for the patients, right? You first first and foremost, you just tell the patient that there's some diet that they can start making it a habit for them, some lifestyle changes and all that, depending on what the underlying problem is, the suspected underlying problem is, at least. um, and you can prescribe. Sometimes maybe it's the problem is drugs like NSAIDs, corticosteroids and stuff like that. So the cessation of such drug, the intake of such drug is also important. So you just tell the patient, okay, this things, this is dyspeptic syndrome, this dyspeptic problems that you are going through. It's possible that it's because of it's one of the side effects of such drugs, and so I would now suggest or encourage you to not take these drugs anymore. And maybe if there are any alternatives, you can try such alternatives. So that's that. And besides that, if you suspect, like what we talked earlier on, this organic dyspepsia is mostly inflammative in nature, right, or ulcerative in nature. So you can prescribe your antacids, first. What antacids to prescribe? What antacids to prescribe? That really depends on what the patient has. Can somebody those who were in our class, our diarrhea and constipation class, Can somebody tell me the two main antacids that we have? In the market. Come on, people. I've talked about this many times. Also, you should know as well because it's very simple and it's good to hear that I'm not talking to a wall all this while. So come on, people. The two antacids. Nobody. Really?
Aluminum hydroxide.
Aluminum hydroxide and
Magnesium hydroxide.
magnesium hydroxide. Okay, which one will cause diarrhea? Which one will cause constipation? I talked about this. Did you write this in your book or anything? No?
Magnesium causes diarrhea.
Okay. And aluminum
Aluminum
cause
causes constipation.
constipation. Okay, good. Thank you very much. So aluminum hydroxide causes constipation and magnesium hydroxide causes your diarrhea. And both of these antacids they work antagonistically. So if your patient comes in with dyspeptic syndrome, and you see intestinal dyspepsia, and you see constipation. Of course, you do not give aluminum hydroxide. You give magnesium hydroxide, right? If the patient comes in with diarrhea, non-bloody diarrhea, of course you don't give magnesium hydroxide. You give aluminum hydroxide, right? You need magnesium hydroxide as a laxative for its laxative effect in constipated patients, right? So there's that. And then after 4 weeks with all these things that I mentioned earlier on, with the doing endoscopy and diet and lifestyle changes, cessation of drugs, and um, to give antacids. After 4 weeks, we'll see what the problem is. Of course, that this means that the patient may not be very acute, right? And of course, if you see that problems like acute gastritis, of course you see like maybe acute uh, maybe peptic ulcer with complication and all that, with perforation or bleeding and all that. Of course, you don't waste time anymore. You don't waste time giving antacid. You of course give more concrete treatment when you already have something such magnitude of problem. But if it's just mainly just dyspeptic problems and not much, not really that severe, and or not really, that significant, you can just maybe time is on your side. Probably just tell the patient this is it, and ask the patient to come back up in 4 weeks or so, and see if the symptoms persist. If the symptoms persist, then of course you will have to do other tests as well, like your Helicobacter pylori test. We'll talk about. I'm not going to explain a lot about this because we'll talk about this when we talk about peptic ulcer. Helicobacter pylori test, both your urea breath test, your and all those things. So then you can start prescribing proton pump inhibitors and your H2 blockers as well, your pantoprazole, omeprazole, esomeprazole, your ranitidine, cimetidine, and all those things. Only then you'll start putting only then this step comes into the picture. Why don't we give proton pump inhibitors immediately? Because of the side effects of proton pump inhibitors. They can cause diarrhea, they can cause headache as well. And the most effective proton pump inhibitors is esomeprazole, and also that is the recommended proton pump, the best proton pump inhibitor that is recommended by the Maastricht guideline. But the thing about esomeprazole is that, of course, it's very effective. It's the best proton pump inhibitors out there. It's also very expensive. Not very expensive, but quite expensive than the usual omeprazole. But people are concerned of the clinicians are concerned of the side effects, and it seemed that the patients tolerate pantoprazole better than esomeprazole. So, well, esomeprazole or pantoprazole is good enough. But sometimes if you don't want to prescribe esomeprazole, pantoprazole, because they are good proton pump inhibitors. They are the latest generation of proton pump inhibitors rather than the usual omeprazole that we use to prescribe and lansoprazole. But yeah, we've kind of the clinicians nowadays have kind of graduated from prescribing lansoprazole and omeprazole, and they started prescribing pantoprazole and esomeprazole. So there's that. Only then you, after this step, then you go ahead and do more radical treatment for dyspepsia and finding out the underlying problem. Okay, so that's a very rough run through of dyspepsia. Any questions before we move on?
I have
Yeah.
postprandial fullness after eating. Can you like explain more? Because isn't it just right to feel full after eating?
Yeah, agree. After we eat, of course, we feel full, right? It's not like the sensation where, oh, I feel so full, my tummy is big. I feel the food up in my diaphragm and stuff like that. It's not that type of feeling. It's a bad feeling, like when you eat and you feel maybe it's not the excessive eating kind of thing. You eat your normal amount, and then you feel bloated. You feel like you're like this. It's just so full. It's just so full, and you know yourself that you did not. It's not the usual kind of amount, the excessive amount of eating. That's what postprandial fullness means.
Understood. Thank you.
Okay. Any other questions before we move on? No? Okay. Let's move on to nausea and vomiting. Let's move on to nausea and vomiting. I think these two terms are quite straightforward. We understand what they mean, right? Vomiting simply means, the exit of your stomach content into your mouth and out of your mouth, right? And nausea simply means the sensation of wanting to vomit, right? And these two terms are quite straightforward to understand. But there's some terms that I would like to point out that people may or you may we sorry that we maybe may be confused about on what's wrong with my English today? Okay, so first term is eructation. Eructation. Eructation or belching. Eructation or belching. This simply means burping. Not the exits, the expulsion of gas through the mouth. Burping, basically, a very layman term. Eructation. And next is retching. Retching. What is retching? Retching means that that person is vomiting, like the act of vomit is there, but nothing, it's an unproductive vomit. Like it feels like something is coming out, and all that. It's not the sensation of wanting to vomit, but it's just the act of vomiting itself has already started. Just that the vomiting act is it's unproductive. It's unproductive. So that's retching. So these are some terms that we need to be aware of. Or sometimes if the patients, if your patients are English speaking patients and are they come with such complaints, depending on which regions or which region that you get to work in, right? Okay, so the thing about nausea and vomiting, when we talk about nausea and vomiting, is that we need to understand that the problem the problem in nausea and vomiting is twofold. One is that we need to understand that there is a central part of nausea and vomiting, and this is the first fold, and to understand that the center of vomiting is in our brain. I think I don't remember where it is. I think it's around somewhere around the fourth ventricle or somewhere like that. Um, but there is a specific center for vomiting in our brain. That's number one. And second, it's a vagal tone problem, not problem. It's stimulated by the vagus nerve as well. So the problem here is twofold. One is in the brain, and one is in the peripheral. Not kind of, you can call it peripheral nerves. And also we need to understand that nausea and vomiting is somewhat like a protective mechanism or a protective reflex as well. Just like your cough, just like your sneezing, just like your diarrhea, and yeah, all diarrhea, you want to get rid of toxin, sneezing and all that. It's reflex. It's reflex. So understanding that it's reflex, it means that the body is trying to protect you. The body wants what's best for you, in other words. So for some diseases, although the patient complains of nausea and vomiting, sometimes, of course, this is highly on the discretion of the clinician, of the practitioner, to prescribe, of course, because different patients, they have different problems and all that. So we need to understand that because this is a sort of like a protective mechanism, protective reflex kind of thing. So the prescription of antiemetics, in other words, the giving patients drugs to suppress the nausea and vomiting, sometimes it is unwarranted, or even sometimes not even sometimes even contraindicated. So we need to understand whether it's indicated or contraindicated, in other words, the prescription of antiemetic drugs. There can be a number of reasons that can cause nausea and vomiting. Really a number of reasons, not just GIT problems. It can be result of some drugs, motion sickness, Cancer patients, especially when they go through chemotherapy and radiotherapy, nausea and vomiting is a very, very common problem in such clinical setting. So for these reasons, this prescription of antiemetic is very, very important. And I don't know why we've never been taught on how to prescribe antiemetic in such situations. Um, Up till now, I've never had any class in school where they properly teach us how to prescribe antiemetic, and so it's not even being talked about during antiemetic. Okay. Anyway, there are a number. I would like everybody to really read on antiemetic and which antiemetic affects what. There are different receptors of when it comes to antiemetic drugs. Some of them are H2 receptors, some of them are dopamine receptors, some of them are well, you can read up. I think there are about 4 or 5 classes of antiemetic drugs. And there are some of them are even like opioids, neuroleptics as well, because you want to suppress what's in the brain, right? Of course, that is a very strong drug, and that is why you don't just simply give, let's say, you give an opioid just because you want to solve the problem of nausea and vomiting. Nausea and vomiting, that's not logical, right? So, but the the very, very common antiemetic drug that is prescribed for patients, and I don't think it's wrong to give such this drug because um, it's quite indicated in a lot of cases, a lot of situations, and that is metoclopramide, METO, metoclopramide. I even have one here, right here, with me, metoclopramide. It's available over the counter and very helpful for nausea and vomiting. Cheap too. Readily available, safe to use even in pregnancy and all of that. So well, so problems with nausea and vomiting, this can help. Of course, you need to when you take such antiemetic drugs, you need to take with your brain as well and prescribe with your brain as well. If nausea and vomiting is warranted and you want to it's a protective mechanism, you don't suppress it, of course, right? Um, that's that. Another one is domperidone. Domperidone um, is not really as the use is not as common as metoclopramide, but it's also being prescribed, domperidone. Next, we understand that nausea and vomiting sometimes can be due to motion sickness. Motion sickness, right? If you're traveling and maybe you're going on a plane and you feel nauseous and all that, and you're vomiting because of motion sickness, or you're in a bus, you're reading, and then your brain just does not understand what's going on, and you feel very nauseous easily. Maybe you're in a marshut. That happens a lot of the time, and yeah, or you're going down from a very high mountain, and it's just like then turning down like this, like this, like this. When you go down, you feel nauseous. Motion sickness, a very common problem. um you don't, of course, give metoclopramide. You would prefer to use something that acts centrally, and the most common drug to prescribe for motion sickness is hyoscine. 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 Depending on where you're from, of course, another name for it is scopolamine. Scopolamine. I think in Malaysia they use hyoscine. I think scopolamine is in the States. I'm not really sure. Or in the UK. Not really sure which one. Well, they're both the same thing. Hyoscine. Okay. Besides that, we need to also understand that in chronic diseases, when nausea and vomiting is clear here, is very prominent here. We need to also understand that the patients might have electrolyte disbalance as well. And we understand the hypovolemic shock is not just merely due to bleeding. It can be excessive vomiting as well. So if we don't treat that prophylactically, the patient can easily go into hypovolemic shock, right? So yeah, so understanding that, we can give oral rehydrating salts prophylactically. Next, when it comes to vomit, of course we need to know that the quantitative and qualitative property and characteristic of the vomit. How much is it? What's in the vomit? Is there blood in it? Um, is there a special smell to it? What's the color? Um, and is it accompanied with something else? Is there any foreign particles in it, and stuff like that, right? So the quantitative and qualitative nature of the vomit is also important. It gives us a picture of what the problem is. Okay. So I think that's all that I can think of when it comes to talking about nausea and vomiting. Okay, we'll move on. Is there any other questions? We have three more things to cover. Three more problems to cover. Okay, no. Next is dysphagia. Third problem is dysphagia. Dysphagia simply means swallowing and swallowing with difficulty. Swallowing with difficulty. And when it comes to dysphagia, we need to understand that it can be a mechanical block, or it's motility dysfunction disorder. Mechanical block or motility, the problem of dysphagia, difficulty in swallowing. That's the first thing. Our thought process. That's how our thought process should be directed towards. First, whether to rule out whether it's mechanical block or a motility problem. It means that something is mechanical block. Simply means something is blocking it, be it intraluminally within the esophagus, or extraluminally, I mean like from outside. Examples of this so-called intraluminal problem inside the tube. It can be cancer, esophageal cancer, gastric cancer, and whatnot. It can be a foreign body inside the lumen, or if it's extraluminally, sometimes cancer that is extraluminal, something else can compress the esophagus. For example, what's that cancer called? Verhoef's node. I think it's called Verhoef's node. I think it's a metastasis, a form of metastasis of any cancer into the sternoclavicular area, and because it's a metastasis, it can compress your esophagus as well. Besides cancer, sometimes your lymph nodes can enlarge as well and compress your esophagus. So that's that too. And this falls on a mechanical block, whether it's intraluminal or extraluminal. Motility problem, we know that esophagus, it has its own, movements, right? Peristalsis and all that. So sometimes the the movement, the peristaltic movements can be erratic and causing spasm. Sometimes it can be local spasm, sometimes it can be a diffuse spasm, sometimes it can get so severe that it's got esophageal um, diffuse esophageal spasm, and they call this phenomenon corkscrew esophagus. You know, corkscrew, right? You know, like the cork on top of a bottle of champagne or something. The when you open the champagne, that swirly thing. Yeah, they call it corkscrew esophagus. So that's that. So first, first thing when a patient comes to you complaining of dysphagia, what are the things that you need to find out? You need to ask the patient, what, why is it difficult for you to swallow? Is it difficult to swallow solid food or liquid food or solid and liquid food, right? If it's difficult to swallow both solid and liquid food, which one is more difficult to swallow? Solid food or liquid food? Is it easier if the food is both liquid and solid? Is it easier to swallow the liquid first part of the food or the solid part of the food, right? So if it's solid problem, solid part of the food, we understand that it can be some form of stricture, or the lumen can be closed for whatever reason. Maybe it's achalasia, maybe it's esophagitis and stuff like that. We'll go through such diseases when we start studying diseases. But yeah, the nature of the food that the patient swallows is important here. Next, is it, you need to ask the patient, is it difficult to make that swallowing movement? Is it difficult to make that swallowing movement? What does that mean? You know, when we swallow, we need to first make that swallow movement, right? And that swallowing, the act of swallowing initially is voluntary, and only when it gets in, it starts to become involuntary, and it becomes the peristalsis, right? So is it difficult to make that voluntary part of that um, uh, swallowing? So if it's difficult to swallow, to make that swallowing movement, the problem can be not in the esophagus. Maybe it's in the pharynx. Maybe it's in the pharynx. So that's that too. Third, is the swallowing painful? Or the medical term for it is odynophagia. Odynophagia, painful swallowing. Is it painful? Fourth, we need to also put this into a timeline. Is the dysphagia intermittent? It comes and goes. Is it constant, or is it getting worse? Intermittent, constant, or is it getting worse? Next, when you swallow, do you see a bulge coming out of your neck? Or sometimes when you gargle, the patient gargles, do you on any drink, or during drinking, do you see any bulging or outpouching on the neck? Because that can be because of pharyngeal pouch. Okay, so these are kind of the line of questions that you need to have when dealing with the problem of dysphagia. Okay. Any questions before we move on to two more problems? Final two. No? Okay. You might maybe wonder how to treat such problem, right? You might maybe wonder how to treat a problem. So, you treat the problem when you find out what the problem is, honestly. It's not like the nausea and vomiting and dyspepsia, like the two things that we've talked about previously. Um, because there's no drug that can kind of help you to swallow better. If you know what the problem is, you know what to give. If it's spastic, maybe you can give um, spasmolytic and stuff like that. So the problem here is mostly etiological. Okay, so if there's no question, let's move on next to malabsorption. Fourth problem, malabsorption. Now, this is a very, very interesting thing to talk about because, again, disparity of um, disparity in different resources. In Russian resources, they call this malabsorption and maldigestion. But then again, dyspepsia is indigestion. So why is there why is there two things that sound the same? But according to USMLE and resources from the UK and also textbooks like Kumar and Clark and Harrison, they only call it malabsorption. There's no maldigestion there. So that's that. Um, so when it comes to malabsorption, the signs and symptoms of such malabsorption is quite important. Just from the term malabsorption itself, it means that there's difficulty somewhere to absorb the nutrients or the product of digestion, right? So sometimes the type of absorption here is important. So malabsorption, it can be selective, meaning that other things are quite okay, the absorption of other things are quite okay, or and the problem is just one single part that is not being absorbed. For example, sugar. For example, lactose intolerant patients. That's a form of malabsorption. Just one particular thing, and that is lactose. Next is partial malabsorption, and that is a rather a bigger class of things that is not being absorbed well, not as specific as selective. For example, as a group of sugar, maybe lactose, fructose, galactose, for probably let's say one group of sugar. Next is total malabsorption, a total group, everything. And this is very prominent in celiac diseases. What is celiac diseases? People who cannot take gluten. Why? Because the body has formed an antibody against the protein in wheat. I think it's called a glial protein in wheat, and that if the person takes in food with gluten, the antibody will start attacking such food and causes damage in the mucosa of the mucosa lining of the intestine, and the patient will get diarrhea and stuff like that, and it's not a nice thing. So yeah, and there are also some specific malabsorption. For example, fat malabsorption, iron malabsorption, B12 malabsorption, and things like that. According to MRCP, the malabsorption is also divided into where the problem is, like what we talked about earlier on. Selective, partial, total, and specific, all those things, they are mostly they are not location specific. But according to MRCP, they've kind of divided the causes of malabsorption into intestinal problem in the intestine, for obviously. Mostly is celiac disease, and more rarely, by the way, celiac disease is the most common malabsorption cause, celiac disease. More rare is Whipple's disease of can't think of any other rare intestinal diseases. But anyway, the most common one is celiac disease. It accounts for over 50% or more than 50% of patients with malabsorption. That's first group, right? Intestinal. Second is pancreatic. This is the second most common cause of malabsorption. That is your chronic pancreatitis. Chronic pancreatitis. See that your lipase is low, your amylase is low, basically your pancreatic enzymes are low because of chronic pancreatitis. The patient might come in with complaining with relapsing episodes of acute pancreatitis, and it's been going on for a very long time. And when you perform X-ray of the abdomen, or even sometimes it's visible on the X-ray, sometimes it's more visible when you do ultrasound and all that. You might see calcification on the place of in the projection of where the pancreas is, but that's not like the constant finding of chronic pancreatitis. So yeah, so intestinal, pancreatic, pancreatic, sorry. And third is biliary, group of biliary diseases, the cholecystitis and stuff like that. Basically anything that is biliary. Mainly because your bile salts, your bile also helps in digestion. If the problem is in the bile, you don't have enough bile, and you can't emulsify fats because that's the main use of bile and all that, right? If you can't emulsify fats, then there's that too. Maybe in liver diseases, cirrhosis, hepatocellular carcinoma, and anything that can disrupt the flow of bile, or just the content of gallbladder, then that is your bile. Other causes that are not listed out as intestinal, pancreatic, or biliary includes bacterial overgrowth. Bacterial overgrowth. It means that, you know, our GI tract, we have our own normal microflora, right? And there's just in some patients, such normal microflora is excessive. There's too much of them. There's too much of them. So, and what happens is that this bacteria, they because they are too much, they become sort of like parasites for the body. Instead of you taking the product of digestion, it's the bacteria that's feeding on what you're eating. So bacterial overgrowth. So when do we see, what cases do we see bacterial overgrowth? We can see it in systemic sclerosis. We can see it in patients who undergo some GI surgery. They call it, it's called blind loop syndrome. When you do anastomosis, right? And there's just one loop that is just not, that the flow of the food does not go through it, and because of that, nothing is going through it. So the bacteria that's in that blind loop that is not being used in digestion starts becoming happy because nothing is disturbing their life, nothing is disturbing the house. So they start multiplying in there and populating the area. Next problem is small. It's called short bowel. Short bowel. Also, we can see it in patients with with lymphoma as well, this bacterial overgrowth. Another issue that I would like to point out is that if the patients come with a specific form of malabsorption, for example, a specific class of malabsorption, and this happens a lot, by the way, a lot of time. For example, malabsorption of fats. The patient cannot absorb fat very well, whatever disease it is, and most of the time um, it's your chronic pancreatitis. You see patients come with diarrhea, steatorrhea, and weight loss. These are the three main signs of malabsorption: diarrhea, steatorrhea, and weight loss. We all know what diarrhea is. Steatorrhea simply means fat in the fatty stool. The stool can be very frothy, and it can be floating around, very floaty, and it's not it also sometimes have a very unpleasant smell, although that's what they say, unpleasant fatty diarrhea. But then again, in just normal diarrhea, I don't think, well, not just diarrhea, just normal stool, I don't think it smells fine. So I don't understand. Sometimes I don't understand why they call it very bad smell. But anyway, they describe the smell of steatorrhea as if they're saying that the smell is like a very putreficative smell, like fat is being fermented. That's what they say. Fat is being fermented. I don't know how you ferment fat, but that's what they say. So yeah, diarrhea, steatorrhea, and weight loss. Understanding that they from in this part that there is a specific class of food that does not get absorbed very well, and that is fat. Um, it means that there are also some other nutrients that does not get absorbed well. And you know that there are water soluble vitamins and fat soluble vitamins, right? So if you are not absorbing fats very well, it means your fat soluble vitamins do not get absorbed as well. It means your vitamin A, D, E, and K, right? So this uh these vitamins can be, your body might be deprived of such vitamins as well. So problems with such vitamin deficiency will arise as well. For example, vitamin K, you might not be bleeding very well. So when you do prothrombin time, prothrombin, your APTT or in your PTT, you might see that there's some problem in your coagulation. And for example, um, vitamin A, for example, if you have problems with deficiency of vitamin A, you might have night blindness and stuff like that, right? So understanding this is that it's not just a specific set of things that does not get absorbed well. There's a cascade of problems that may come together with such problem. Okay. All right. Last but not least, before I hope that I have time to cover this one, I think I'll just briefly go through it, and that is pain. The problem of abdominal pain. You can call it acute abdomen, you can call it whatever. Uh, well, we're not talking about surgical problems here, although they like to divide acute abdomen into internal medicine type of acute abdomen and the surgical type of acute abdomen. I'm not going to talk about that. I'm also not going to talk about the quadrants of the abdomen because I assume and I believe that everybody here knows um, the 9 quadrants of the abdomen, and the localization of pain in such in any quadrants can be reflective of what problems. I assume everybody is fluent or proficient in it, and the differential diagnosis that we can have on all these 9 quadrants of the abdomen, right? I'm also not going to talk about how these nine quadrants come about. Where do the lines come from? I'm not going to talk about it. I assume that everybody understand that. You just don't simply draw your 9 lines, because it's just a landmark that you have to follow, right? For example, on the vertical line, you follow your omin-clavicular line. And okay, I'm not going to explain it, but I assume that everybody will know how to divide the abdomen correctly, not just simply draw the line. Okay, so but what I would like to talk about is the nature of the pain itself. I'm sure maybe some of us are already aware of this. If not, I'm just going to just point it out again. When it comes to pain, not just GIT pain, any pain in the body, and pain is a very common complaint from a patient, right? The easiest way, or it's important to understand how the pain how that pain comes about. So I'm sure maybe some of us have heard of the acronym Socrates, SOCRATES. So S stands for site, right? Where it is localized and all that. S stands for site. O, onset. When it begins, or what did the patient do in the beginning of the pain, onset. SOC, character of the pain, whether it's sharp pain, dull pain, what pain, this pain, that pain, the character of the pain. R, radiation. Radiation. It means that there can be some form of referred pain as well. Okay. SOCRA, associated symptoms. May be associated with nausea and vomiting and other things. SOCRAT, time. What is the duration of the pain? How long is it? E, exacerbating or elevating factors. What can help, what worsens the pain, and what elevates the pain? What makes it better? S, severity. Severity. How do we gauge the severity of the pain? You give the scale of 1 to 10 to the patient. Ask the patient, from a scale of 1 to 10, how do you rate your pain? 7. Okay, so you understand what that means. Okay, so understanding this, you ask the patient such questions. Very important. Okay, this acronym is very commonly used in clinical settings, so I don't want you to forget. All right, so there's that. Next thing that I would like to talk about is the nature of pain itself. Pain, or in other words, nociceptive factor, noxious factors, or in other words, factors that can cause pain. They call it noxious factors. Okay, they both affect nociceptive receptors. I'm not going to talk about the pathway of nociception and all that, where it goes, where does it cross, and what type of receptors are involved in it. If you're interested, I highly encourage you to find out to study the pathway of the nociceptive pathway of pain. And understanding this, you will know what type of analgesia you want to prescribe to the patient, whether you want to give opioids, whether you want to give NSAIDs, whether you want to give serotonin antagonists, sometimes even antidepressants that can help to elevate pain. So I will encourage you to study that, okay? Because different things can affect pain differently, and to understand what can help the patient to elevate the pain. But anyway, nociceptive pain can be divided into, I think you know this already, somatic pain and also your visceral pain, right? And somatic pain then divides itself into superficial, and that is your skin, and your deep somatic pain, and that is your muscles, your ligaments, your tendons, your fascias, and stuff like that. Whereas visceral pain is mostly in the organ itself, right? Parenchymal organ, your liver, your spleen, your kidney, and stuff like that. So that's one thing that I would like to point out. Next is the character of the pain. I wouldn't call it character of the pain, but I would type of pain. You can say nature of pain. You can say it that way as well. But anyway, first and foremost is spastic pain. Spastic pain. You understand what that means? It means that uncontrolled spasm. Next is spastic pain, distension, this pain because of distension pain. Next is peritoneal pain. Irritation of the peritoneum, not necessarily just the organ itself, not just merely visceral pain, because you know your peritoneal leaflets, they have their own nerve endings as well, and once they get irritated, it can elicit pain. Most like that. Last but not least, vascular pain due to vascular in nature. Okay. Another form of pain that I want to talk about is referred pain. I'm sure that is quite obvious for us. Referred pain simply means a pain that is not in the localization of the locus, or the localization of problem. Okay, so understanding these different types of pain. Let's say the pain is spastic. Do you give NSAIDs? Do you give opioids? No. Why? Because the problem is spastic. So you give spasmolytic, right? So there's that. If it is something else, maybe it's visceral or not somatic pain. Of course, you give NSAIDs and all that. But you have to be careful as well, right? Some GIT problems that elicit pain, like let's say peptic ulcer or gastritis or Crohn's disease or all those inflammatory diseases. Do you give NSAIDs? No, right? Because NSAIDs will make it worse. So you don't give NSAIDs. You give something else for the pain. You give something else for the pain. Also, it's not spasmolytic when it comes to GIT problems, because we are really concerned of NSAIDs. Really, really concerned of NSAIDs. NSAIDs can cause a lot of problems. A lot of problems. Not even paracetamol. Paracetamol is very hepatotoxic, and also not even very encouraged when it comes to GIT problems, giving paracetamol. Okay, so that's that with pain. Any questions? Again, I feel like it's very on the surface. If I were to really talk more, I'm not really quite satisfied with the depth where I'm going with this. I hope it's quite clear enough. No questions?
Yeah, please. After the class, can you just help me send the link? I know my network was not too stable. I would like to go there.
Okay, no problem.
Thanks.
Okay. So no questions here? Ah, we are today on time, 8:29. Okay, so if there are no questions, next week we will start with talking about diseases. I don't know what to start with just yet, whether we want to, yeah, start according to the GI problem, like maybe from the mouth downwards till the end. We'll see. I'll think about it. If that's the case, maybe we can start. If we want to start next, we can start with the esophagus. Maybe esophagitis, biliary waste, diverticulum, Calicia. Well, Calicia is a very important thing to talk about. Okay, anyway, I'll let you guys know what to cover next week. And I would encourage everybody to read up on them. Okay. All right. So if there's no questions, you guys have a wonderful evening. Sure.
Thank you.
That's,
Bye
all
bye.
right. Bye-bye, people.
Thank you.